was preparing for another kind of webinar like today. It was about assigning homework, doing the best practices for assigning homework, getting the most effective results out of assigning homework to our patients. And I was preparing for it, and I went over this with Jill, who you've all just heard, and she was saying ahead of time, saying, I think you have a lot of material here. Are you sure that you have enough time to cover it? And so come the day of, I got really nervous, as I tend to get in these kinds of presentations, and I start talking really fast. And of course, I go through all of the slides within like 30 minutes of the hour presentation. And then the rest was Q&A. And it was a pretty lively Q&A. And the feedback that we got was, oh, it seemed like you kind of ran out of material after 30 minutes, but the Q&A portion was really nice. And so we thought, maybe it's worth kind of learning from that a Q&A type of meeting can be very useful and meaningful to people and more engaging. So that's kind of how we got to today. And as we were thinking of what to do, how to kind of start off this maybe a series of Q&A, having some of those Q&As kind of be fairly regular as part of our series every first Wednesday of the month that we provide. Floating the idea of maybe doing this on hopelessness, because we noticed that in our training which we do over at Feeling Good Institute weekly, we have our consultations. A lot of the toughest cases have to do with what to do when our patients are feeling hopeless or showing signs of feeling hopeless, feeling really stuck a lot of times with that. And so when I floated that idea into the certified listserv, got a lot of great responses, and I thought, I think we're onto something. This could be great to be able to give provide some help and support to the therapists out there in this kind of tough topic, tough for everyone. Jill, do you want to take it from here?
Yes, I do. I was just muting. Someone had complained about an echo. So when you're not speaking, presenters, just mute yourself. And I think that'll help the echo. So welcome, everyone. We're excited to do this Q&A today, and we hope that you'll learn a lot. I'll just go over a couple of quick things with you, and I'm also going to introduce the presenters to you today. And to my co-hosts, if you do see Erik, you're welcome to spotlight him and make him a co-host as well, so I can introduce him. So we just wanted to say that we'll be recording today so that you all can have access to this recording, and so people who aren't present can have access as well. So if you don't want to be on the recording, then just don't just hide your video, although I think the way we have it set up, you won't be on the recording anyway, but just to protect yourself, you can do that. And then if you are interested in the recording, we'll post it on the workshop page so you can access it in the future. So just a few words about who we are at the Feeling Good Institute. So everyone presenting today is from the Feeling Good Institute, and it's our mission to alleviate suffering by nurturing elite therapists. So the way that we feel that we can best help those who are suffering in our community is to deliver really high quality training to therapists. And so the Feeling Good Institute was started by Maor, Katz, and Angela Crum and myself, and a group of therapists who were mentored carefully and closely by David Burns at Stanford University. And we work hard to train and certify therapists in the processes of effective therapy. So we train therapists and deliver therapy using routine outcome monitoring or measurement. We teach therapists really powerful empathy tools. We work on increasing motivation and reducing resistance in all of our patients. And we also teach and train and practice in the art of cognitive behavioral therapy. And the therapists who are with Feeling Good Institute are really highly skilled and vetted therapists and trainers as well, some of them. And we all engage in weekly kind of rigorous continuous improvement. So case consultation with deliberate practice so that we're constantly improving our therapy skills. We offer video-based treatment across the United States and Canada, and also in person. We have treatment centers in New York City, in the Bay Area, in Canada, and in Israel. And we offer traditional outpatient therapy as well as intensive therapy, where we offer therapy to patients for many hours a day, many days a week. And sometimes people come in from out of town to do intensives with us. And we're proud to have some really good low fee options as well. And Maor, you need to move the slides for me. So I'm going to introduce our panelists today. I'll only say a word about myself, and then I'll focus on the rest of our awesome panelists. So I'm a clinical psychologist and one of the co-founders at the Feeling Good Institute, and also the director of training. And I've been practicing CBT, I was trying to count, for almost 30 years and teaching it for almost 20 years. And I'm excited to be joined by some really fantastic panelists today. So first, join me in welcoming Maor Katz, who is a board certified psychiatrist and the director and founder of the Feeling Good Institute. And Maor completed his residency in psychiatry at Stanford. This is where he met David Burns and was inspired by David Burns, and has been kind of learning and teaching and training in team CBT since then. And he's still on the adjunct clinical faculty at Stanford. Maor really loves helping patients with addictions, anxiety, and mood disorders, and also specializes in couples therapy and relationships. And he's co-authored many papers in the field of depression and mental health, and has won many awards for his research and education. And most recently, Maor and Mike Christensen are co-authoring a book that's called Deliberate Practice in Team CBT, which will be published in the coming months. So we're excited about that. I'll move on to Mike, and Mike is our next featured panelist, Mike Christensen, MACP RCC from Canada. So Mike serves as the Director of Professional Development at the Feeling Good Institute and plays a really key role in helping others in their growth and development to become really phenomenal therapists. His clinical specialties include anxiety, depression, and habits and addictions, and he provides really wonderful online training and consultation with the Feeling Good Institute for therapists around the world. So I'm excited that Mike is joining us today. And then next is Richard Lamb, LMFT. Richard is the Team CBT Certification Program Manager at the Feeling Good Institute, and he also teaches CBT to therapists worldwide and provides therapy and training in person and online. And his specialties include OCD, panic disorder, and focusing on relationship problems. And Richard also hosts the Feeling Good Therapist, which you can find on YouTube, where he kind of teaches and demonstrates a variety of CBT techniques and mentorship to help clinicians and patients to learn these CBT techniques. And then finally, I'm going to introduce you to Erik Wilkerson. And Erik is a postdoctoral fellow at the Feeling Good Institute in Mountain View. He's been practicing Team CBT since about 2017 after joining David Burns's Tuesday group at Stanford. And Erik also offers therapy in our low-fee clinic. He loves seeing couples, anxiety disorders, and depression. And Erik graduated from the PGSP Stanford PsyD Consortium in 2022. And a fun fact about Erik that was shared with me recently is that he's featured in something called the Sip of Conflict at San Francisco's Exploratorium Science Museum, which highlights the experience of an OCD patient. So I thought that was a cool thing. So that's our intros. I'm going to turn it over to Maor. I'll also say the plan is that Maor is going to do a presentation for us, kind of a brief presentation, and then we're going to present some vignettes to our panelists and give our panelists a chance to respond about some specific vignettes. We'd also love you to send your questions to me or send your questions in the Q&A box. So that's how you'll submit questions today. You can open the Q&A box at the bottom of your screen, submit questions, you can upvote other people's questions, and then when it comes time after presenting vignettes, I'm going to turn to that Q&A box and read your questions to the presenter. So we really hope that you'll be very interactive today through polls, Q&A, the chat box, etc.
Thank you, Jill. Yeah, and I want to start with a poll actually, um, and launching it right now. So the poll is asking the question: is feeling hopeless good? Is feeling hopeless important and good for you or your patients? And as you're kind of filling in this poll, I'll share with you a story for me, for my life. It was in the winter, a few years ago, I went on a ski trip with my kids up to Tahoe. And on our way, it was kind of getting dark. We got stuck in the snow in the middle of nowhere, kind of a few miles away from Kirkwood, if anyone knows where that is. And so I was, of course, wasn't phased. I came out of the car and I started jacking up each wheel really and putting something underneath in order to get out of the snow and be on our way. And so I did this with 1, 2, 3, and 4 wheels because they all were stuck. And then that all took me about maybe an hour and 20 minutes to get all the wheels out of the snow. And then I got into the car seat and I, moved turned the engine on and moved forward 2 feet and sunk right back into the snow. And then I was filled with complete hopelessness. And that was really good that I was filled with complete hopelessness, because then otherwise I would, of course, spend the rest of, I don't know, the night or my life or something, inching forward a foot at a time for, for each hour and a half of work. So instead, we spent the night in the car. It was actually really sweet. I was kind of scared, but my kids remember this as like a wonderful experience. And to me, this is a good way to explain why feeling hopelessness is important. And let me share the result with you. And so you see that some of you said yes, some of you said no, about 50-50. And of course, the idea is that it's not, the reason that I'm kind of asking this question is it's because it's kind of counterintuitive to think that feeling hopeless is in any way a good thing. And it's also going to be counterintuitive for our patients. And that's it's going to be part of our challenge. As we set out to do this presentation, we asked in the certified list, or the Team CBT certified list, so what are some challenges that you've had with hopelessness? And we got a lot of great responses here, and saying how the first step really is in question number 1, like how to respond to someone who's feeling hopeless, how to empathize with this, with someone who's feeling hopeless without sounding too cheerleady, without being dismissive, but who's still also being connected and empathic. And thank you, Anne, for sharing that. And LJ made this really great question about kind of noticing that there's kind of a correlation between feeling hopeless and people are not doing homework. So we can see that our patients tend to not do their therapy homework when they're feeling hopeless. And then, of course, that's a big problem. And if we just demand that they do their homework or else kind of thing, that's not going to necessarily help, because what's keeping them from doing the homework maybe is just feeling quite hopeless. And there were a number of other answers, really about over 20. And these are the main ones that I think capture a lot of the challenges that the rest were bringing up. And I was kind of thinking about this one by Nancy, how patient is stuck in learned helplessness. I think really what Nancy is saying is when people are feeling hopeless, they're really stuck and they don't see a way out. And it's like this feeling that both the therapist and the patients get in the room of feeling quite stuck. And what I'd like to do now is actually launch quickly another poll. And it's going to be almost my last poll. But check this out. And this question is, which one of these patient statements or situations indicate they're feeling hopeless? And you can answer more than one. So that's the idea, is that you can answer more than one. So see if any one of them, all of them, some of them give us a sign that maybe this patient is feeling hopeless. And I'll give it maybe one or maybe 5 more seconds or so to fill. I see a lot of you have already answered. And the point of this poll is to kind of bring to your awareness, everybody's awareness, that hopelessness has a lot of faces. And this is really kind of my first tip to share with you about kind of how to approach feeling hopeless is first to look for it, because it really looks in all these very different ways. And usually our patients are not, often they won't say, hey, I'm feeling hopeless, but it's something that you might notice and you'll need to kind of help bring it to their conscious awareness. So I see that most of you kind of answered all of those, and we'll go over, I think, all of those in our Q&A and kind of how to approach all of those situations in today's meeting. So this is, I'm going to go through now a series of 6 tips, and that will come together to form an approach to how to, I suggest, to help you approach hopelessness in the room. And the first one is look for it. That it has all these different ways of appearing, including saying it outright, but also just not doing their therapy homework, or maybe kind of demanding or really needing to get a technique that really helps because they tried other things, and that what you suggested last week didn't really help as much. They tried it, but didn't really help. Is there something else? And that's another kind of way that it shows. You can also just feel kind of this kind of listless, stuck feeling in the room that we sometimes have when there's a feeling of no hope. So the first thing is look for it. And then the second thing that I want to suggest is, once you notice it as a therapist, I kind of have it in my mind, this kind of picture of like clearing the desk, moving everything aside, and just focusing on the hopelessness until it's resolved. Like nothing else will work basically until we figure out how to handle, how to deal, how to support patient and feeling less hopeless and more hopeful that therapy has something for them to gain from. It's easy to provide a rationale, and I would suggest you kind of practice kind of thinking about it. So here's a suggestion that some version of it is usually what I say, kind of the reason why we're kind of pushing everything aside and putting it front and center is that hopelessness is a self-fulfilling prophecy. And so it'll just be a complete wrench in our wheels, and we'll want to focus on it whenever we get even a whiff of it. And I kind of mention it, kind of start talking about it and I suggest you find your own language, and whatever of this is you feel is useful for you, by all means. Something around getting into the patient's conscious awareness that hopelessness is a self-fulfilling prophecy, and that's and therapy won't budge, won't really progress until we kind of focus on it. Saying that, for those of you who are familiar with the team CBT approach would know that Dr. David Burns always teaches us to first look at the advantages of the symptom, or of in this case feeling hopeless. So then the next step, after you're kind of making it to the focus of the therapy, comes a time to examine, take kind of a little bit of a paradoxical approach and examine all the good and great things that hopelessness does, and we can think about it together, right? And is whether it's like just saving us from disappointment is one, or like the case in that I had in the snow up in Tahoe, which is kind of realizing that it's a waste of energy to do something, or whether to kind of communicate to others that we're having a hard time here and we need help, external help. Like I needed a tow truck to come. I needed to make sure that my body was smart enough to tell me, hey, this is not the right avenue, call the towing company. And so there's all these advantages to hopelessness, and we want them to come from the patient in their own words. We just want to help them kind of start to think about it in this kind of counterintuitive way. Once we have that list of advantages of the good things it says about us, about the patient, the hopelessness does and what it does for them, then we, as a therapist, you have this in front of you, and you can use it as a devil's advocate for hopelessness. So this makes the patient actually argue against the hopelessness. So if you put yourself in this position mistakenly of like a cheerleader, kind of saying like, oh, you shouldn't feel hopeless because it's a total self-fulfilling prophecy, then the patient's job is stuck in being like, well, I hear you, but I think it's still, it doesn't help me. I actually feel quite hopeless. But if we switch it around and we become the devil's advocate, we've in a way force the patient to be in the role of arguing against hopelessness. Because if we say to the patient, hey, you sure you want to give up on hopelessness because it's really important that you don't get disappointed. It's better to feel hopeless than disappointed again. Disappointment is so painful. Then they can say, and they can argue back to it, no, I'd rather be, I'd rather try. I don't want to just like give up. So the idea is that you want to be the devil's advocate as soon as you can. And the last tip that I will share with you is to assume that it will come back again. To assume that it's not like, so usually when I say like move everything aside and center on that, focus on that, usually that takes between 1 and 3 sessions to work on, or 1 or 3 hours to work on hopelessness. And then we're kind of in a better place, but it probably will come back 2 or 3 sessions down the line. And at that point, you and the patient already have like a common language about it, and you can kind of talk about it. It's like, oh, I wonder if there's a little bit of hopelessness coming up again. So maybe we can take a look at that, maybe kind of review our notes or the work that we did before that was helpful. So putting it all together, here's kind of generally what I suggest you do as an approach to dealing with hopelessness. First is look for it. And then the next step is going to be to use empathy to bring it to the patient's awareness, because it's not always going to be fully aware. Usually it's not. So ask kind of these kind of gentle questions that usually it's better to minimize. So to say something like, I wonder if you're feeling even maybe just a little bit hopeless or discouraged right now. Is that what's going on? And so if you're kind of minimizing it, it puts the patient in a place where like, yeah, I can kind of normalize it. Yeah, I can see that. Maybe I am. And then ask him to tell you more about what they're feeling. And so start a conversation about hopelessness, bring it out of them, of the patient talking about it. And once you have a little bit of a conversation going and it's kind of clear that they're feeling hopeless and they're recognizing that as well, you want to measure it so you know what you're dealing with. So on a scale of 0 to 100, how helpless are you feeling right now as we're talking about it? And then can give you a number, and you can know where you're going then, and they will as well, how you're doing as you do some work on it. Then you go to listing the advantages of the hopelessness feelings. And once you have the list of advantages, then you can go back to the disadvantages. Because sometimes the patient will be like, that keeps me just as stuck. I'm now not only feeling hopeless, but I'm seeing all the advantages of feeling hopeless. That means I'm going to continue to feel hopeless. And so once you kind of did all of that, then you want to go back to the disadvantages of hopelessness. And I would always favor keeping it kind of a milestone in your mind. You want to get the patient to see that it's a self-fulfilling prophecy. You want to hear that from them, or kind of, or you can, if they say the words, yeah, I can see how it's a self-fulfilling prophecy. You can say, yeah, I see that too. Can you tell me more? How do you see it becoming a self-fulfilling prophecy? What do you mean by that? You really want to see that the patient has got kind of a buy-in to the understanding of the problems of hopelessness, the self-fulfilling prophecy, and that kind of counteracts the advantages and makes them still want to kind of overcome the advantages of hopelessness to overcome the hopelessness itself and move forward with therapy. And once they have that buy-in, then you can go into this devil's advocate position of siding with the resistance and being the devil's advocate and having the patient argue against hopelessness. So this is kind of putting it all together. And so this is my last poll. And it's kind of more like a review question, just to kind of help you just think about it for a minute longer about this kind of approach that I'm suggesting. And so what I'm asking you to do here is say which one is in the right order. Which of these options is in the right order? Let's give you a minute for it. Kind of think about what makes sense to you. Yeah, I'm going to give you maybe 5 more seconds, but I can see that there's an overwhelming majority, 91%, are saying that it's a number 2, and that's exactly right. So we want to start with, in your mind, realizing, okay, let's make it the center of therapy. I'm noticing hopelessness now here for my patient. I'm going to make it the center of therapy. I'm going to start by empathizing and bringing that out to conscious awareness. And then once I can see that we're talking about the same thing, I'm going to measure it, discuss the advantages, then the disadvantages, then be a devil's advocate to melt it away. So this concludes my, yes.
I'm gonna interrupt you with a question since it's a Q&A, and like
Yeah.
I've got a lot of people
Perfect.
asking one particular question that feels super appropriate for you to address now.
Thank you.
So, and then we'll do the vignettes, of course. But so I've gotten a lot of questions actually directed to me specifically in the chat box rather than in the Q&A about suicidality and hopelessness. And I felt like it was super important for us to clarify our position on that, because I think it makes people feel very anxious, totally understandably. But so questions such as a patient with intense hopelessness may be suicidal. Would the therapist be the devil's advocate in this case? Is this, unsafe? Would we be pushing someone toward suicidality? And questions about, safety planning. And I think, so I'll let you kind of go ahead and answer that.
That's a perfect question. I'm so glad you stopped me here. And I think we could probably give a whole course, not just 1 hour, but probably a full course of 24 hours or something like that of how to work with people's suicidality and hopelessness in that context. As a psychiatrist, I can tell you that that's in a way kind of it's been my bread and butter, right? Is work day in and day out in assessing people's safety, and hopelessness is certainly part of it. If you are, so there's kind of like 2 parts to this. It's such a complex question, but there's, in a way, as a clinician in these situations, you have kind of 2 hats. One hat is, first, I need to make sure that my patient is safe. So there's this assessment. Is this person safe to go about their day? Or do they need a higher level of care, or even go on an involuntary hold? And so there's like this assessment of safety that's always happening. And so once you kind of check that, I think they're safe for now, then I can go on and connect with them. And the question that specifically was, and then it would be with this approach that I'm suggesting. And when you're doing kind of a cost-benefit analysis, the advantages of hopelessness, it's not the advantages, it's never going to be the advantages of committing suicide. I've never sit with a patient saying like, what in a therapy room and talk to them about the advantages of them committing suicide or the disadvantages of them committing suicide. If that's the talk that I'm having, I better have that in the hospital. But I can have a conversation about something that's close to that. And that's actually very apropos this first case that we have here, because oftentimes part of the hallmark of people who struggle with borderline traits is having chronic suicidal ideations. And the idea there is like same kind of thing. First, you want to assess, is this person safe to be in an outpatient setting, or do they need a higher level of care? And once that is checked, you can work with therapists, with patients, on a slightly but a very importantly different kind of cost-benefit analysis, which is what are the advantages and disadvantages of feeling hopeless? And also, in the case if it's even closer to suicidality, and do this only with the appropriate setting and supervision. But I have found myself having one of the more meaningful meetings with some of my patients where we discuss the advantages and disadvantages of having suicide as an option in their lives. Like they're saying, I'm not chronically suicidal, don't get me wrong, but I have this, I'm kind of thinking about that as like, I know that if things go terribly in my life, it gives me some solace to know that I can exit. And that is something that I can work with. As a psychiatrist, I feel comfortable working with that. It'd be really important. It could be very meaningful, important work. So this is even a step beyond hopelessness. Again, the point that I'm trying to drive is that you never want to be in a situation where you're doing a cost-benefit analysis for or against committing suicide. The cost-benefit analysis that you're doing is to see the advantages and disadvantages of feeling hopeless. And you start to help the patient have this perspective. This feeling is something that I may be able to find a way to have some control over, some power over, if I'm starting to think about it as something that I may or may not need to have, almost as if I can understand why I'm having it and choose to fight back against it. That's my long answer. Really, the longer answer is we should probably do a whole series, of course, about this super challenging, kind of scary, right? Scary topic.
Thank you. That was wonderful. Just wanted to make sure people felt that that was adequately addressed. So that's great.
Yeah, and so let's go back to this vignette. And this vignette is based both kind of loosely on a number of patients that I've seen, that I've worked with, that were like this, were challenged by similar challenges, and also based on the questions that people asked to be answered on the listserv, on the listserv. And so for this, just to bring it to life, let's imagine that we're working with Anne, who's 32, and she's struggling with bulimia and body dysmorphia and some borderline traits. And she says to you, gosh, I'll never be able to show myself in public, right? This body dysmorphia. I'll never be able to show myself in public. My fiance is about to give up on me. And you're probably ready to give up on me too. Now, before we turn this to Mike Christensen, to answer some specific questions, I want you to enter in the chat box to Jill, how would you start to talk with Anne about her hopelessness? What would be some of your starting moves, empathy statements, ways to get her to talk about hopelessness? I'm sure that all of you can see that Anne is feeling afraid and hopeless as part of what's going on. And Jill, you can facilitate maybe answering, letting me know, letting Mike know when and how to proceed.
Great. I will do that. Also, just a reminder to people, if you have specific questions, enter them in the chat box rather than enter them in the Q&A rather than the chat box, because I'll be looking to the chat box for answers to some of our questions, and then your questions might get lost. One person, Seth, said, it sounds like you're feeling pretty discouraged and somewhat hopeless at this moment. Someone else said, it sounds like you might be beginning to feel hopeless. Yeah, I'm wondering if you're feeling hopeless. And some people are saying provide empathy and inquire if they're feeling hopeless. So I think you're getting a lot of similar connecting to the hopelessness, offering empathy. You're worried that people in your life will give up on you. I wonder if you're feeling a bit discouraged and hopeless. It's hard to imagine that things will ever change.
Oh, I love that. What a great response.
Yeah. I can see that you're really suffering with the idea that you can't show your face or be out in public and feeling like people are going to give up on you. This must be really upsetting. And maybe you're feeling like you're all alone. So we're getting lots of really beautiful empathic responses.
Fantastic.
Well, I'm already loving what I'm hearing, and it really leads to the answer to that first question, which is how would you respond to Anne's hopelessness without cheerleading, condescending, or dismissing? And I would say all of those answers would fit the bill for me. We empathize, we connect with Anne, and some of those were really beautiful responses. I might say something like, you know, Anne, I want to pause for a moment because something you said is so important. Imagine that you're feeling maybe alone, scared, a sense of despair, and feeling hopeless. And that seems actually kind of justified, considering that you're concerned that you'll never be able to show your face in public and your fiance is going to give up on you, and thinking that I'm going to give up on you too. It's got to be incredibly discouraging and sounds painful. Help me understand what this is like for you, even talking about it right now. Tell me a little more about what you're experiencing.
Great.
I love that. So Jill, are you gonna
Sure, yes.
take these questions up with Mike now?
Yep. And so I'm just going to clarify one more time. So put your questions in the Q&A and then your answers to our questions in the chat box. And that way we can keep them separate. So if you put some of your answers in the Q&A, I deflected them just so that we can see clearly what your questions are. So yeah, Mike, well, I'm going to ask you a question about this vignette. A couple of people have asked, actually, can you tell us more about, like, what are some examples of the benefits of hopelessness? You know, Maor talked about it briefly, but I have gotten a bunch of people wondering more about that. So I wonder if you could maybe even just speak to what could be, if you were having that dialogue, that positive reframe with Anne, what would be some potential benefits or positives to her hopelessness? And then we could maybe go to question number 2. What if she then struggled to speak back against her hopelessness? Because that was actually in the Q&A a lot of times.
Yeah, it's such a good question. And it really, you need that setup ahead of time. And it can be hard to think of what are the benefits of hopelessness. What are the advantages of feeling hopeless? And so when I'm working with a patient or client and they're stuck on figuring that out, I actually draw from some of my own personal experience and the experience of other clients that I've worked with, and lean on a couple of things. One is the hopelessness actually has a protective quality to it. You know, if you get your hopes up too high when you've been disappointed over and over again, that seems like a bit of a setup, right? Like when, like Anne, you've struggled with a number of things and have probably reached out in a variety of ways for help, and it hasn't been helpful. Every time you got your hopes up, you were disappointed. And so now this hopelessness that you're hanging on to keeps you a little more realistic, keeps your expectations in check. And so it shows that you kind of value being honest and genuine, and it protects you from that disappointment. The other thing that it can do, and there's literally, a number of them, but one that really resonated for me when I look back on my experience of having a really difficult time was I'd been through an incredibly challenging time and was feeling really awful. And if somebody said, "Oh, just be hopeful and be happy about life," it would have been like dismissing the difficulty that I'd been through, the pain and the struggle, and minimizing it. And so the hopelessness, in a way, validated my struggle, validated the pain I'd been through. And it was a little bit of a self-loving, compassionate way of looking at my life. One other one is it, just kind of points to the fact that you value this integrity and this honesty about the situation. Everything isn't wonderful. You're being actually genuine and honest. Your hopelessness points to that. And it can provide a bit of temporary relief. It can give you a bit of a break, right? It can give you a bit of a free pass. It's like, oh, it's not going to work anyway, so why bother trying? It can allow you a bit of a rest in the moment. And when we're really struggling, that rest can be a wonderful thing. So acknowledging those things is really important. It was powerful for me in my journey, and for many patients and clients that I work with.
Wonderful. And Mike, one of the questions that we got, which I think is question 2 on this slide, but that several people put in the Q&A, was, what happens if you do this kind of beautiful positive reframing that we're talking about, really leaning on kind of the benefits of hopelessness in a very authentic and warm and caring way. And then you kind of, as Maor suggested, you maybe go to the other side and say, yeah, I'm wondering if there are any disadvantages, any reasons to give up your hopelessness. And what if your patient says, not really, they kind of side with the hopelessness. And we did get a couple people asking that in the chat box and in the Q&A as well.
Yeah, and I'm so glad this question came up, because in those moments it can feel like, oh no, what do I do now? Right?
Yeah.
I've led them down this road. And so I think this is where, for me, you're going to really hone in on what the specific advantage is, and clarify that with them, and then do a little bit of measurement with the hopeless as well. So if I'm doing kind of the devil's advocate and saying, yeah, but your hopelessness really is protective of you. You're not going to get your expectations too high. And they say, yeah, that's right. Then my response would be, well, maybe it would make sense for you to continue to feel hopeless. You said you were feeling 80% hopeless before, and maybe we'd actually want to hang on to that and not change it. Why would you want to let that go? And then allow them to ponder that. And we want to be careful not to kind of suggest all the disadvantages, other than there might be that educational piece that Maor talked about before, right? Where we're looking at the self-fulfilling prophecy, where it can undermine the work, which is, I think we're going to touch on a little bit later. But
yeah. And I'll ask if any of the other presenters want to, Richard or Erik, I'm going to turn to you with some other questions too, but if either of you have anything else to add to what Mike has said, please do feel free to, unmute and join in.
Great. I'd love to.
So go ahead, Erik.
I just love to riff a little bit on what Mike and Maor have said. One of the reasons why we do the positive reframe table, the cost benefit analysis, is sort of the secret sauce at team, is this idea that if you come directly at a client and the symptoms or the problems, in this case, hopelessness, it elicits resistance, right? And that resistance comes from that sort of unarticulated part of ourselves that recognizes that that behavior actually serves us in important ways. And so hopelessness is one of the stickiest behaviors, because it does serve us, even though it's counterintuitive. So that's the purpose of the positive reframe table. And so in this moment where a client is not arguing for change or arguing against the hopelessness, one beneficial sort of method that we use in team is like sitting with open hands, right? Like, it's not my role, and this sounds very untherapeutic, but it's not our role to argue or convince a patient to change. Our role is to be an invitation, right? If you want to, I will help make these sort of unarticulated reasons for hopelessness. I'll help make the implicit explicit, and then you can make the change, or you can decide to make the change. And if you don't want to make the change, I'm happy to offer empathy. That's in itself, the research shows, is therapeutic, right? It has benefits. But at the end of the day, kind of sitting with open hands. And I've even said, like, I'm here to be an invitation. If you want to think and be differently in the world, I have methods that can help you. And I also recognize that hopelessness serves, based on what we just discussed, the positive reframe table. And believe it or not, that actually helps a lot, right? Because hopeless people have heard from mom and grandma and their boyfriends and their spouses, like, oh, just feel better, right? Everyone's trying to push them to change, but to have somebody say, hey, you can be hopeless. It's okay. And you tell me why you want to change. That kind of changes the feel of therapy, and actually changes the dynamics a lot. So,
Erik, I love what you just said. And I often will say, when I think back to my journey, hopelessness was my best friend. And right now it's kind of yours too. And it would seem cruel of me to take that away from you. And so I'm right with you. Tell me what this is like.
Yeah, and what both of you are saying, and beautifully said, Erik, is, that we're not trying to help patients against their will, right? That we're only going to be effective in therapy to the extent that we're collaborating with our patients and that we have an agenda that we both agree on. And so if the patient is clinging to their hopelessness and the therapist is trying to convince them away from it, then we're at odds with each other and not going to make any progress. So if we can kind of join with our patients and wonder, why would you want to give it up? Then quite often our patients will jump to the other side and kind of argue for change.
One significant thing I just wanted to share, and I'm a little concerned about time, but I wanted to share a little bit of, I think this is probably the most respectful thing that we can do for our patients. A lot of times people might feel like it's manipulative, like some sort of like, I guess being a little paradoxical might feel a little manipulative, but I think it's also, or it is actually more of a respectful thing, because you really get to know someone's cultural background. You understand their point of view of how they perceive the world, what is important to them. And who's it, like as a therapist, I don't know if it's my role to tell them this is not important, so you should give it up. And when we dive a little bit deeper, we understand why this is important to them. And it's up to them to convince us if this is something they want to give up too, because there's a lot of meaning behind each one of these emotions. And it speaks to the person that they are, their background, how they grew up, and their culture, their religion, whatever it may be. So I do think this is a very important part of treatment.
Let me ask Richard, sorry, I know we're jumping around a little bit, but I think this is the nature of a Q&A that we get to do this. So I'm going to ask Richard a question that he just kind of partly answered, but I got several questions about this. I think it's super important. And I know, Richard, you really wanted to speak to this as well. So the question is, I'll state it the way Julia stated it. My concern with labeling hopelessness as a self-fulfilling prophecy is that it might diminish the external hardships or suffering that could be outside of their control for clients, especially for marginalized clients, people of color who face racism in the workplace and then feel hopeless. So is there a way to honor these circumstances that doesn't put the onus on them entirely? So there was a concern about the self-fulfilling prophecy and just sort of how do we honor hopelessness in environments that are, to some extent beyond the person's control. I'll turn that to you, Richard.
Yeah, I'm so glad that that's a question in this training here. I think it's just so important to know that every person is in different situations, different economic backgrounds, different cultures and different struggles. And sometimes it kind of makes sense to feel this way. And that's why when people are telling me I'm hopeless for a reason, and there's so many good reasons, I want them to highlight that they can feel really good about, actually, there's importance why I'm feeling these emotions. And it's kind of like a way to kind of protect myself or to motivate myself to try something different. And a big part of hopelessness is there's so many good things about it. Personally, for me, I wouldn't want to give up my hopelessness completely. I know Mike spoke to this a little bit, but just to share a little bit about myself, I came up from a really challenging background where very low social economic status, and always worried about money and feeling hopeless all the time about what are the next steps, when are we going to get food on our table next. And hopelessness and anxiety really helped us motivate ourselves to kind of get to the next step. Like, what are we going to do next? Worry about and think about what to do next. Hopelessness of things not working, so therefore we have to try something different. So that way we give up on that thing and try to find a different solution. And a big part of this is maybe it doesn't make sense to give up hopelessness for some. And it's really up to them, because they know their background more than we know it. They live it day after day. We only know a snippet of it 1 hour each week. And it's going to be important to understand more during this process.
Wonderful. I'm going to ask one more question, or actually, can you go back one? There was one question that was asked a couple times. Sorry. Yeah. So the question that a couple of people asked, which is the fourth question, which is, what if Anne said, are you giving up on me? Because I got a couple people that in the chat box said, so what if the patient says, so are you giving up on me, when you're sort of siding with the voice of their hopelessness? And then we'll do the next vignette with Richard, and Erik, feel free to jump in.
Yeah, this is a tough one to respond to, and I've had this happen in the moment. You're like, oh, and so once again we make sure we're empathizing, connecting with them, because there's some sense that they're feeling like we've given up on them. So I might say something like, "Wow, Anne, my heart just sank a little when you asked if I was giving up on you, and here you've come to therapy and trusted me to support and help you, and to question whether I'm giving up on you. I'm sensing that you might be feeling worried and frustrated, maybe discouraged, maybe alone and hurt. And tell me what you're experiencing right now. Help me understand. This is important."
Wonderful. Yeah. So we'll want to empathize and disarm and try to understand more about what the patient is thinking and feeling. Maor, I'll let you, thank you so much, Mike, for your answers to many of those questions. I'll let you introduce the next vignette, and we'll just spend a few minutes on that, and then we'll wrap up. We're running out of time.
Yeah, and I just want to add to that previous beautiful statement, a response by Mike, to say that I probably would start my empathetic response to saying something like, "Oh, Anne, I'm never giving up on you. You always, as far as I'm concerned, you always have me on your team." And then I'll go into the rest of it. Because I think that maybe it would be a little bit harder for her to receive it without first kind of getting that relief. And then, okay, it's not just cheerleading, then let's go and talk about it. So we talk about Steve. Steve is also kind of a similar case where I can think of several patients, some of my toughest patients that kind of fit this profile, who is a person who's had some success in life in his career, but is in a very tough spot, recently divorced, struggling with depression and alcohol overuse, and to a point where he's not even showing up at work most of the time. And now every time you meet with Steve, he asks for tools to battle his depression. He says something like, I did some work. It didn't really help me that much. I need something else. And he's been coming back each of the past 6 sessions, feeling just as depressed and pleading for more help with a technique that maybe is more effective. And so this is a tough case, right? And so very suitable for Richard to answer some of those questions that kind of come up here in the little bit of time that we have. Jill, do you want to take those questions to Richard?
Oops, sorry, I was unmuted already. Yes, so we'll just spend a couple minutes here, and then we have one slide we want to share at the end as well. And we'd like people as well to go back to the workshop page and give us some feedback at the end. So yeah, let me maybe move to, I'm going to ask you question number 3 first, if that's okay, Richard, just because it's more unique in terms of what we've covered so far. Richard, how do you think you would connect this request? You know, people might not even pick up on it, that this kind of constant request for new tools. How would you connect that to feelings of hopelessness for this patient?
I think it's kind of like the elephant in the room kind of situation where we kind of see this pattern play out of, we ask them to do some homework and they do a little bit of it and they're like, what's next? They don't fully commit to it. And I think there's a skill that we use, and some of you might know it, called change the focus, where we share what we've noticed within the session and the pattern that keeps happening, and just to talk and empathize about it a little bit more, rather than giving more methods, and then kind of going into letting them know how the treatment looks like and what we would need in order to make it successful, in order to move to the next process.
Great. And I think also, again, sometimes these questions depend on context. And so, it's very different if a patient is engaging in therapy and doing their homework and using methods, and the methods we've used hasn't worked, then maybe we're thinking we'll move on to other methods, versus the patient is not really putting in effort and energy and engaging in the methods, but keeps asking for new things. And that feels more like a sign of hopelessness and kind of lack of effort and connection in therapy. So how about one more question for you, Richard, or do you want me to go on to the next one, Maor, because of time?
Yeah, no, we can I think elaborate on this question or have more one more question.
Okay. Great. Let me just see. Yeah, so actually, someone asked, I thought this is a good question, Richard. I don't know if you feel comfortable answering this, I can turn on to someone else, but would you use what we call changing the focus? And then were you using sort of a gentle ultimatum? We don't need to use our team language, but like share more about how you might address that if maybe that's the second one, but how that hopelessness is interfering with doing homework and making progress in therapy. How might you address that?
Absolutely. I want to give a quick answer to this one, but at the same time, I know it's a more elaborate. So essentially what we would do is, for example, if you needed surgery and you told your doctor not to use any like surgical tools, I think that'd be very challenging. And in the same way, a big part of what we're doing is we're going to help them with their depression. And in order to do it, we have to make that or allow them to do some homework, and also to give up hopelessness. And how the gentle ultimatum works is I can give a really quick version of it. It would sound something like, so Steve, I'm just imagining we're doing our work together, and I can't help but feel really sad to kind of hear what you're going through. And on the other hand, in some strange way or another, I can't help but feel a little excited imagining you kind of getting your life back together, going to work again, having extra skip in your step every day, and just with a big smile on your face and feeling really happy. And now that I'm thinking about it, I can't help but feel a little sad, because I'm thinking maybe you wouldn't want that, because what that would mean is you would have to give up the hopelessness and work on the hopelessness with me, and also do very consistent homework of an hour a day of homework, even though you don't feel like it's working, you're going to do it anyways. And when I think of that, I'm thinking maybe I'm asking too much of you. And don't get me wrong, of course, my preference is that you do want to do this work and tackle this with me together. And at the same time, I'm also thinking maybe I am asking too much. Am I getting that right? And
Great.
this is just the gentle ultimatum in a really quick version.
Yeah, and what I'll say is, and we'll move on to wrap up here, but I want to say we have so many creative ways, and we could spend many hours, I think, addressing this, which is clear to me based on the number of questions and comments. And so I'll just say, and then I'll just say a few things in closing, but thank you to the presenters. We have so much to offer our hopeless patients, including empathy, but way beyond empathy. And thanks for laying this out for us, Maor. We'd love to invite you all to join us next month. Every month on the first Wednesday of the month, we'll be doing either a Q&A like this, or actually a CE presentation. And next month, our presentation is going to include one CE. It's on September 6th at noon Pacific, and focusing on CBT for anxiety in children and adolescents, presented by Taylor Chesney from FGI New York. So we hope you can join us for that, and kind of put a bookmark on the first Wednesday of the month at noon Pacific to join us every month. And next slide, Maor. So we'd like to say thank you for joining, and also just tell you a few things about what we have to offer. If you're considering getting more expertise in Team CBT, we offer certification and training programs. And if you have any questions about them, you can reach out to us at certification@feelinggoodinstitute.com and find our trainings on the Feeling Good Institute website. If we've inspired you and you're interested in joining us at some point and interested in a career in private practice, you can get in touch with Sonia, and her email address is on this slide. We believe in fostering a community of passionate and compassionate therapists, and we'd be delighted to tell you more about becoming a Feeling Good Institute therapist. And lastly, if you know someone who could benefit from our services, whether that's a friend, a family member, or a client, you can also find therapists on our website at feelinggoodinstitute.com. So we really hope that you enjoyed us today. We'd love to hear from you. We can put a survey on the workshop page. So if you have a moment to complete that, give us some feedback. Let us know what you liked, what you didn't like, what you'd like to see more of. We'd love to hear from you. So thanks so much to the presenters, and thanks to everyone for joining us today. We look forward to more with you in the future.
Thanks, everyone. Thank you, Jill, for doing a wonderful job emceeing this event.